for joining. We are excited actually today to have Dr. Mike McShane. Mike, if you don't mind calling me Mike. Mike is an associate professor of medicine at the Penn State College of Medicine. You'll see why we're especially excited about his talk because, as you know, our CTSC had put together a strategic plan for rural communities, for doing research in rural areas. A new objective for our CTSC. So we have a plan that we would like to implement. And as Mike, I'm sure knows, it's not easy. Rural communities have been, in our application when we renewed the grant in 2023, we did specifically say that we want to increase access to clinical research for rural communities. And we're in the third year of the grant, and we're just starting to implement our strategic plan. So it's they told us, UPI as well as others who work in the space, told us to take our time and have a lot of patience. It's not easy. So we'd like to learn from you as much as possible. So to go back to Mike, so he's associate professor, as I mentioned, of medicine at the Penn State College of Medicine. He helped to establish and lead the Lion mobile clinic effort over the past 4 years. His research and educational interests focus on the intersection of education, health systems, and sustainability. He seeks to identify health interventions designed with and for communities. He earned his undergrad and medical degree from Penn State, as well as a master's in education from Harvard. He completed his residency at Cambridge Health Alliance, a Harvard teaching hospital, where he served as chief resident. So Mike, we're very excited to have you, and thank you for joining us today. All yours.
Well, hey, thank you so much for having me. I'll say I'm an Ohio native, so I grew up at a town, Springboro, Ohio, just south of Dayton, and so it's good to reconnect with folks from Ohio and share a little bit about it. At this point in my life, I've been in Pennsylvania more than I have been in Ohio, but I still consider myself an Ohio native. So thank you so much. I sort of named this talk "Where the Rubber Meets the Road," and what I hope I can share is some of the higher level philosophy processes that we use with the Lion Mobile Clinic and how that relates to research, but then also somewhere the rubber meets the road, some practical advice of boots on the ground, things that we've learned over really the past 3 to 4 years since we launched the mobile clinic. So just to share, I sort of outlined a couple learning objectives. I'm first going to jump into some of the framework, inception, mission of the Lion Mobile Clinic as we got this started. And then I wanted to highlight 2 pieces of sort of our research infrastructure in terms of collaboration and how we recruit in communities. And then finally, I was going to touch on sort of the translational impact that mobile clinics in particular can have for research as these initiatives grow really across the nation. So I don't have any disclosures to report, but I put this slide in because I don't know if it's a disclaimer or maybe an apology to start off with. Penn State grad. This picture I think is probably pretty emblematic of the presentation today. So this is one of our Airstream units that's right in front of Penn State and Beaver Stadium where the football team plays. And just in the background, there's that Penn State logo you can kind of see. I'll say that I think what has made this initiative grow is really embracing the culture within Pennsylvania. So Penn State and that emblem, that Nittany Lion that I have on my shirt today, means so much for communities in Pennsylvania, especially in rural communities. And so, much of what I'll describe, I think, really tries to encapsulate and leverage that culture of the university. So you might see that in some of my slides. And in an example I'll share here just to kind of paint the picture. So we went out to a dairy farm about 2-3 weeks ago. So I'm involved in a research study with a couple other colleges here at Penn State. And the study is about biosurveillance. So we're looking to see if there's been previous serology positivity for H5N1, for bird flu that's been spreading. So we go out to different dairy farms that I've been to providing services as a physician, and that our vet has been to for years providing consultation to the farmers. And I'll collect serology samples from the farmers, farm workers, and then he'll collect samples from the cows, and then we run it at Penn State. And, with the changes that have happened federally, I think it's been challenging. There have been farms that we've gone to where farmers are fearful that the farms will be shut down in the case of positivity, and also farm workers that are terrified that ICE is going to show up. And so with those, we've had challenges recruiting at farms that we've been to consistently. But 2.5 weeks ago, we go to this farm that was about 3 hours away that was really interested in being involved. And when we went there, there were 3 workers there, all 3 from Guatemala, 3 women, and then the farmer and his wife. And as I was collecting serology samples from the humans, the vet was out getting samples with the cows. We finished collecting samples and then started to do some basic screens that we'll do for folks at locations that we go to, and answer any questions that we can in terms of medical questions that they might have. And at the very end of this visit, one of the farm workers came up to me and she showed me her phone. And on her phone was a picture of her daughter, and her daughter was in front of Beaver Stadium. And there's this sign that's right in front of Beaver Stadium that says the Pennsylvania State University. She was in a cap and gown. And so she was sharing with me that her daughter graduated a year ago from Penn State with a finance degree and was working at a bank locally. And so I think about, here's this lady who has, gone through so many obstacles to come here and work at a dairy farm, and had done so many things to get her daughter through education, how proud she was to give back to the university and be a part of this study. And so, I think that example of 2.5, 3 hours away from our campus, of how passionate and connected people feel to the university and to our culture of sports, was really, I think, emblematic of what we are trying to leverage and work with throughout Pennsylvania and the Commonwealth. So anyway, let me jump into a little bit more of the background of the mobile clinic. So I'll start here with just describing a little bit of the inception of how we got started with the mobile clinic. And to do so, I could continue to blabber on here, but I'm going to share a short video that was created by our marketing group about a year and a half ago. So bear with me technology-wise. I think I figured out the kinks, but let me get it started here, and I'll be back with you after the video. This really started with Snowshoe, Pennsylvania. So a community just north of us was hit really hard. Lost its grocery store. It burnt down in a fire, along with its hardware store. Lost its bank, its pharmacy, and then unfortunately its clinic shut down. So we at the College of Medicine, our students, faculty, staff really rallied and said, is there something we can do to help? We're a student-run free clinic that provides care to underserved populations around Center County.
There's so much more to care about a patient than just the problem that they're presenting with.
How do you earn the trust of the community as you get out there and get people to come see you?
It's all about relationships. It's really rewarding as a Penn State graduate to be able to go out and serve the community in different ways. And I think what we really try to do is blend in those opportunities of teaching, research, and education.
The students try to help educate the seniors at the center on ways that they can improve their diet through healthy eating.
As far as produce and fresh meat and stuff, it's not available up here.
So if you can't access fresh food, produce, you're not going to access medicine.
Not enough attention is paid to rural healthcare. We talk about the we are spirit, that it's not about us, it's about the communities we build. And I like telling everyone that we're the only land-grant university in Pennsylvania. meaning that someone may or may not be a Penn State, or we may not claim them. But I tell you what, every one of them has a claim on Penn State. What you do gives opportunity to these communities to thrive as well. So that's fantastic. Thank you so much. Thank you, thank you, thank you. Thank you.
So every time I watch that video, there's the one scene where one of the older adults is cutting the avocado. And we've unfortunately had a couple of accidents and had to do some laceration repairs. So, a really great community up there. And, I think one of the things about Snowshoe is, here's a picture of it. This is downtown into its main area. Snowshoe's, like many other communities and rural communities across the country. So was a coal mining town, had a lumber industry, was pretty robust for years. And then as those industries left, so too did opportunity and investment within the community, and sort of had this steady decline until 2021-ish, when they lost so much of what was left in the community. And so, as we've sort of expanded throughout the years, Snowshoe is one of the many communities that we continue to interact with. The other thing I'll say too is that I think as we've done more and more about this is that, as no surprise, the challenges that exist in Snowshoe are multi-sector. It's the loss of economic opportunity. It's the challenges with financial stability. It's all of these other social drivers of health that are affecting people's health down the road. And so as we've expanded, I think some of what we've done is sort of tried to expand what we do. And so this is just a map of Pennsylvania to give you a sense. In fiscal year 24-25, we did about 100 events across the state and different communities, including Snowshoe. And so we've been fortunate as time has gone on to expand our footprint. I'll share a little bit more about what our fleet looks like, but we're able to sort of expand our fleet to 3 trucks and 2 Airstream units. And then our funding sources as well has sort of covered a couple of different external and internal sources, including our own CTSA, which has been supportive of some of our research initiatives as it goes with the mobile unit. The other piece of this whole intervention, as sort of mentioned in the video but glossed over, is that from the very beginning, research has been embedded in the mission. And so when we started to go to Snowshoe and other communities, we have a rural sociologist that was embedded with us to understand the needs of the community, to understand what we were doing in terms of impact for that community, and then flex, decide what we needed to change. And that was really critical, especially as we started to really decide help work to identify what we needed. And since then, we've continued to grow and have this combination of both service and research and education. So I'll talk a little bit more about that, but that's been a critical piece as we've sort of continued forward with this. So I'll share our mission and vision. I'll tell you, as I was sort of preparing for this, I think we're probably due for a good whiteboard session of rehashing the mission and vision a little bit. But really, I think what sort of as this is defined is that as we've grown, what has remained core is about the health and well-being of both the individual and the community. And so many of the interventions that we've created or partnerships that we've focused in on has been back to that. How can we create sustainable solutions for rural communities? Really that piece of leading with service, and then leverage some of the research power and other parts of the university to help fulfill those needs. And so, as time has gone on, as for me as a physician, of course, there's this real interest and focus on healthcare access and quality, but really we've started to think about access for other resources. So that includes resources to partner with our College of Business and help with financial stability of communities. It's working with the food distribution network and trying to identify ways that we can help with the supply chain. It's all these other things to try and help to provide access to communities as a key part of what we do. And then the other thing I'll say too is access is being one critical piece that we do. The other piece is about advocacy. So many rural communities and communities that are underrepresented lack that ability to share their voice and really affect change. And so I think what we have almost become at times is the megaphone to speak to policy, to politicians, to try and affect change at a more county level, at a state level, and affect change. And so as much as we have been heavily focused on this question of access, and healthcare access as being part of that, the other piece of this has been about advocacy and really trying to allow the voices to be heard of those that don't necessarily have the platform to be heard. So probably a little bit of workshop. I think that's, the focus of our mission and vision is really in these lanes of access and advocacy. Okay, a little bit about infrastructure. So here's our fleet. I feel like fleet sometimes is a big word that seems like a fleet would be like a massive amount of vehicles. And we do. We're fortunate enough to have, the 3 trucks and 2 Airstream units. But fleet almost to me connotes much bigger. So I don't want to conflate, the size of what we do, but we are fortunate enough to have this. I didn't mention before, the initial capital to purchase this was actually through congressionally directed spending. So we had a local a congressperson in the House of Representatives who supported a project through the project funding congressionally and helped us to obtain the capital to purchase these units. And I'll share a little bit later about, nationally what that kind of looks like and across for us, the Big Ten, of how folks obtain the capital to purchase these. But here's our 3 units. We've got a Ford F-150 Lightning, which is an electric truck. And then the 2 Airstream units are pulled by 2 separate trucks. Airstream, an Ohio company based in Columbus. We had they work with one customization group in particular, which was fantastic to work with. And so I'll show some pictures here of what it kind of looks like on the inside for us. But fantastic group to work with. Basically allowed us to work with the shell of the Airstreams and then build it from the inside to sort of fit the needs that we were hoping for. And so here's kind of a closer look side by side, not quite to scale. The top picture is this flying cloud unit that's a little bit bigger. And you can kind of think about it as like 2 office spaces or 2 exam rooms. And then the bottom picture is the base camp model that Airstream has. I got a little bit of a higher wheelbase and is more of like a 1 exam room, 1 office space. It's much more, it's able to go off-roading a little bit more. And so we take it to a lot of our dairy farms or farms in particular. I'll say too, the reason why we chose this model, there are many mobile clinics across the country, some of which are in the larger RVs. For us, the decision was one, Airstreams connote this sort of picture of Americana. And we found that, especially with rural communities, there's this great connection with Airstream. They've seen Airstreams on the road for decades. And so there's sort of this intrigue that draws people in, which has been really beneficial. The second thing is, again, they've been on the roads for decades. You see Airstreams from the 70s. They're still out there on the road working. So it's high quality and will stick around for a while. And then the third aspect of this is really what fails is transmissions and engines. And so, the trucks are a little bit of a lower threshold for cost. And so allows for easier sort of moving pieces of the puzzle in and out. And, we won't necessarily be off the road if a truck fails. We have a backup truck that we can use. And so that helps us to maintain some consistency within the communities that we go to. So here's this is the larger unit, the flying cloud, just a picture inside. So one of our medical students, Katrina, she actually just matched at UMass. So is headed to UMass in MedPeds, really excited for her. But Katrina is in one of our exam rooms. When you walk in just to the right, we have portable exam tables that we will typically use to sort of be more flexible with the space that we have. She's in this picture doing hepatitis C screenings was what we were doing at that event. And then if you look at the top right picture, it's essentially if you're looking into the unit, Katrina would be sitting to the right, but straight ahead is a vaccine fridge, some storage, there's a sink there, and then there's a bathroom in the middle. And then the picture in the bottom right-hand corner is sort of a typical setup, and I'll have this picture again, but just to kind of give you a sense of what the outside looks like. We have a big screen TV on this unit with a speaker system, which allows for different educational material for us to be playing or sort of ability to have some more audio-visual connection with communities. And then here's the smaller unit. This is the base camp. This is the one we take out to more of the dairy farms. The picture on the left, I just wanted to kind of give you a picture of the space of how much space is in one of those. So you can fit a fair amount of people inside of it. But an exam table is set up on the top right-hand corner, similar to the Flying Cloud. They both have a sink and a bathroom. So if you look in the bottom right-hand corner, if you're going straight ahead, that's where the bathroom is located for this Airstream, which has come in really useful for different events. But as you'll see with both of these, we sort of live inside and outside of the unit, depending upon what type of activities we're doing. So the bottom right-hand corner just gives you a setup of an event that we were doing for a field day with some colleagues from the College of Arts and Architecture. So really cool event that we had there, but just kind of gives you that inside and outside perspective of the units. Okay. So, I wanted to share a little bit of this is sort of, I think, the principles behind the work that we do. So Penn State is a land grant institution. That mission was really established by the Morrill Act of 1862. And in that, it mandated universities to provide practical education. So education is part of that, conduct research, and then also perform public service. And so that has been a key part of what Penn State is for the state of Pennsylvania, service as being a really important element of that. And so, as we have created this mobile sort of unit, we have tried to maintain some of this land grant mission. So in terms of service, I think mobile clinic is probably the easiest way to think about it. We provide both clinical and non-clinical services. So the clinical services mostly fit in the bin of early prevention and screening, as well as early detection. So prevention, early detection, and screening are probably the key pieces of that. In terms of non-clinical, we also provide other services. So that includes helping with the food distribution network or other sort of financial services that might be available for communities. And so we try to expand what types of services we provide to the community based off of those needs. And then I'll switch over to education. And I'll talk a little bit about our staffing model, but education is a big part of this, both for the community and our students. We focus on experiential learning as the pedagogy behind this and view this mobile clinic as a mobile classroom. So we have course credit, internships, and volunteer opportunities for students that sort of help us fulfill the needs operationally to get the mobile units on the road. And then finally, research. So I think we are really on the early stages of this, but the vision is thinking about this as a sort of a decentralized location for clinical research to happen and a mobile clinical research center. Focus has been heavily on recruitment, and I'll describe some of that, but then I'll also share some of the initiatives that are starting to push us beyond recruitment and other ways to include potentially the clinical trials on the physical mobile unit. Okay, so staffing model. We rely heavily on our students. So sort of think about this as a way that we can provide course credit, internships, or volunteer opportunities for our students. They cover the gamut. We have over 100 students per year that are involved in some aspect of the mobile clinic, whether that be undergraduate, graduate, or professional students. And then really we use faculty oversight, either for those course credits or internships, and then volunteerism to help with overseeing some of those operations. And so this is an event, just kind of give you perspective of a lot of the students that'll be with us at different locations. And then the other piece of this that I mentioned earlier is that research has been really embedded into our operations. And I'll say that there are probably 3 ways in which that fits in. So one, as we are having events and have a focus on service, we also have researchers that will roll with us in tandem and recruit for studies. So this could be one-off studies or in partnership with our CTSI that will help with that recruitment process. This is really that face-to-face opportunity for researchers. It's more than just a flyer. It's either research team coming with us, the PI, or having our CTSI team that focuses on engagement, helping to be that face. And so we found that to be really beneficial to be physically present while the service is happening. The other is on the right-hand side, continuous quality improvement. We've continued to have different researchers embedded to help us understand the services that we're delivering and the needs of the community, and then allow us to be flexible. And some of the output of that has actually been service delivery. And so this final piece, I think, has been really critical of this connection between research and service. So the example that I'll show, this is, I won't play this video, but our Cancer Institute has created a project, a research study that's focused on cervical cancer screening and HPV self-sampling. So we recently launched this. This video basically walks through how to do this, the HPV self-sampling for it. But it's a research study. And so as we have rolled this out, this has allowed us to be able to provide something like HPV self-sampling in rural communities. And to us, this is critical. We've heard this from the community. We know the numbers that upwards of 60% of women are not quite up to the screening guidelines, and we know that number is less in rural communities. And so as we're going out to rural communities, we have heard this need for additional cancer screens. And so HPV self-sampling as a research study helps us to be able to provide that service. And it's also something that the institution has not yet, from a clinical delivery perspective, been able to do. So this has been like how we've really tried to embed, as we're going out. This is technically a research study, but it also provides us with an opportunity to provide a service to rural communities. And so that has been another mechanism where we've tried to embed research into what we do from a service perspective. Okay, I recognize this is probably part of the talk where a lot of people sign off, so I apologize for that. But, back to this culture of Penn State. So, this is a picture of Beaver Stadium. For football Saturdays, there's upwards of 100,000 people or more in the stadium. But I think the thing that's really remarkable about Penn State is what's happening outside of the stadium. So in any given football game, Penn State College becomes the third largest city in Pennsylvania. And I think that just shows you the magnitude of what sports and athletics draws to the university. 100,000 people in the stadium, there's 100,000 people tailgating outside in the fields. But tailgating, it's a cultural phenomenon. It's a ritual that happens at Penn State and other universities. But at Penn State, there really is this connection to others. It's this conversation of sharing resources. It's not uncommon that people forget things and then the tailgate next to them helps to support it. It also creates this real sense of belonging. As you're walking by the tailgating fields, as long as you're wearing the right colors, usually people are willing to, talk to you and bring you into their tailgate and really have this great connection with one mission to really cheer on the Nittany Lions. And that culture is really powerful, I think. The tailgating experience is really powerful. It's something for alumni and Pennsylvanians that really connect and understand what that means. And so it's interesting. There's another concept out there called tailgate medicine. So tailgate medicine started in the military during one of the Iraq conflicts, and it was in the Army. The concept was, how do we provide the same quality of care outside of a brick and mortar site, out in a combat zone, by literally dropping a tailgate of a truck or combat vehicle or opening a door and providing that care for both service members and also the community. And that concept has created many advances within medicine. One example that I think has been remarkable is the Stop the Bleed kits. So you may be familiar, American Trauma Society has the Stop the Bleed program. It is essentially having this small kit of a tourniquet, hemostatic gauze, and other equipment to stop a bleed in a field so that EMS can get there and potentially save a limb, if not a life. And so these kits have been remarkable of being able to stop that bleed in the field, and they came from the military. The military has gone way beyond that. There are other mechanisms where they've created different tech and have extended out even ORs out in surgical theaters, out in combat zones, or have been able to extend out what we can do medically. And so we're also at this point in time where many institutions clinically have started to do this. So I think of hospital to home programs. There are many institutions that are discharging people from the emergency room and providing hospital level of care in their home. There's point of care ultrasounds that street medicine teams are rolling with to provide care to people on the streets. And so these are all mechanisms that the technology has advanced at such a level that much of what we've traditionally done in brick and mortar clinics doesn't necessarily have to happen there. So tailgate medicine is that sort of example. And so, we have adopted this tailgate medicine model. And so we just recently published an article about this, about the concept of it, but it really is that. It's trying to combine what the military has done in terms of tailgate medicine and extending some of the cultural phenomenon of what happens at a tailgate to rural communities. And so some of this is to lower that threshold. It's much easier to approach a truck. It's much easier to approach a mobile clinic than it sometimes is a clinic. And so this sort of dispersion of potential treatment options to where people are located and doing it in an environment that makes people feel like they have a sense of belonging, connection, can really then help to get people more connected to the healthcare system. And so we adopt this model of tailgate medicine. What it looks like is sort of this. It kind of looks like a tailgate. We have different events that are happening. This picture on the left was actually with our marketing team in dermatology doing skin cancer screens. But if you walk up, it doesn't really look like this is a clinic. It looks like there's some sort of event going on. The same thing's true for the top right-hand corner, where we were doing multiple screens for communities out in a field. And so what we try to do with this tailgate medicine model is blend those sort of the positivity, the nature of the sense of belonging with tailgating and tailgate medicine. It also, I think for us, it's a really provides a connection to the university. I think people have that sort of strong, positive feeling with what tailgating is, especially within the culture of Penn State. Now, I'll take it a step further. I wanted to describe a little bit of what we do in terms of research and how this potentially can be successful. And I think it's similar along this lines of tailgate research. What are the ways that we can provide the same quality of research and investigation outside of our clinical research centers, outside on the road? What does that actually look like? And for us, it looks like this. This is a picture out at a dairy farm. We've got some equipment that's up on some washers, and we've got doing interviews inside the mobile unit. So trying to extend what we do in research, but out in those typical sort of settings, what it might look like. Now, key element to that is engaging with the community. And so I think probably the main strategy that we focus in on, as I've described, is leaning back on this land grant mission. So leading with service. That has been pretty key to what we do. Whenever we go to a new community, most of the time we focus on the service first before we even broach the conversation of research. We try to establish relationships. So I think a face-to-face interaction for us goes a lot longer than a flyer. So focusing on that relationship rather than a transaction has been really key for us in terms of recruiting in different communities and rural communities. And then the final piece is about presence. It's not necessarily about placing here and placing there. It means continuously showing up. And I'll go back to the comment earlier. It's true. It has taken us years for some communities to get to the point that we're at. It takes time. It shows consistency. A town like Snowshoe has been burned so many times, and so it takes a while to build up that trust. We too, I think, with many universities, there's this concern of a poke and a prod, where it's researchers coming in, taking sort of that transactional relationship and not giving back. And so it takes time to develop those relationships. The other piece that's challenging in many of these rural communities, the N is smaller. So a town like Snowshoe or Phillipsburg or wherever is much smaller than some of the urban locations. And so getting an N value to a certain level can take longer and take more communities to reach there. So our focus with this initiative, and as we expand our locations, has really been creating those relationships with communities and then working with them to see if there are research needs or connections that will work with them. So the other piece that I think has been strategically important for us, and so I'll say this slide kind of seems like it's a no-brainer, I think, with some of this, but has been really important. One has been about infrastructure. So we view these mobile units as literally that platform so that we can have the capabilities to do what we can do in the community. And one of the challenges, especially for some of the more remote locations, is broadband access. Internet access can be limited. Phone access can be limited. So when we initiated this, the focus on service allowed us to sort of be involved with different IT infrastructure, including the FirstNet that's built by AT&T, which gives a different broadband connection and allows us to have that wireless connection out in pretty remote and rural locations. So that type of IT infrastructure has allowed us then to be able to do the REDCap surveys and other pieces of research out in pretty remote locations in Pennsylvania. The other piece that has been pretty critical is thinking about how to integrate a mobile clinic and a mobile research center essentially in a university. So a big piece of that has been shared language and processes. It's been working with our IRB to determine what language is needed so that when someone wants to recruit on the mobile unit, what type of language do they need to build into the IRB protocol? So that's been really important. The same thing with biosafety and biosecurity. As we've been collecting samples, having a little bit of a process and working with the biosafety folks to understand what that looks like, so that when the next research study comes through, that's a little bit more streamlined. So we've been working pretty heavily in that this past year or two to streamline those processes as projects has gone on. The other piece has been alignment with our institution. So there's been a heavy focus with us within Penn State University about rural health. And so many of the initiatives, we try to partner with different parts of the university to align those strategic goals with the university. And that has also helped to leverage different resources to get it off the ground going and have more support to make this happen in rural communities. And then the final piece I'll say, it's back to this piece about the platform. As much as we are providing services, the mobile unit serves as really like this space to be a mobile lab. And so some events that includes, we are basically having a shared leadership model of who is in charge of what, how do we get the unit there? It's almost like a renting of a service for different researchers that may have a study that's ongoing to utilize it in a space that they need to do for recruitment or service. And so I'll go back to this photo. The piece about the photo on the left is really our marketing and dermatology department. Cancer Institute and our CTSI have been great partners to roll with us and help with the research initiatives. And so many of the events will be this mixture of people and parts of the university coming together in this atmosphere to do the work. All right, one final thing I'll touch on, and then I'd love to open it up for questions, ideas, thoughts. More than happy to answer anything. Here's the potential. So this is a photo, a great group, Mobile Health Map. It's a nonprofit organization based in Boston. They do a lot of tracking nationally of mobile clinics across the country. And here's just a snapshot of where they're located across the country and multiple different locations. Estimations are anywhere from 3,000 to 4,000 with them. There's probably more out there that exist. It's just not quite captured in this. And, the mobile health maps, they published this landscape report in 2025. And I think the really intriguing piece about this is that growth has been massive. So 80% increase since 2013. Some of this was sparked by COVID money. I think a lot of institutions ended up purchasing mobile units to help with vaccine initiatives or testing. But over 10 million patient visits per year, and a large portion of people without health insurance are accessing mobile clinics. And then interesting in this report, it sort of describes the population. So mobile clinics are reaching underrepresented populations across the board, including one of those being serving agricultural workers and primarily rural locations, but also others, including veterans and military families, and those that are experiencing homelessness. And so these mobile clinics are essentially, I kind of view them as these hotspots that are going into locations, underserved communities. They're creating really strong relationships with communities, and they're across our nation. So this network of mobile clinics exists throughout. Now, there are challenges. I think financially is a big challenge for many mobile clinics, and I'll describe a little bit before I end of one of those challenges that I see. But this infrastructure This network is out there, exists in multiple states in many different locations. You know, I know this might not be as relevant for this group, but for us, you know, one of the ways that I think we think about our mobile clinic initiative is trying to see what's happening across the Big Ten. And so this is a snapshot and may not be comprehensive, but gives you a picture of what it looks like across the Big Ten. And I think a couple interesting points about this. First, many cancer centers are focusing on mobile health and doing outreach as it relates to cancer screening. The second is many mobile clinics, especially those in the Big Ten, are from donor funds. So donations that have come through that are supporting the initial capital purchase with those. And the third is it's not much research happening. Now, University of Oregon does some clinical trial recruitment for theirs, but many of this is focused on the concept of outreach and some service. But it's been interesting to see how that has developed across the Big Ten. And like I said, I don't think this is comprehensive, but just kind of gives you a snapshot of what it looks like across the Big Ten. The other thing I'll say is that as this momentum of mobile units grows, it still is relatively new. So many of these initiatives started in 2022, 2023, 2021. And so there has been this steady growth that more academic institutions are starting to be involved with. So I still think, despite some mobile clinics being around for decades, this is a relatively new healthcare infrastructure that is growing as time has gone on, and it's probably going to be an important one. So I was just mentioning before we started, you know, the Rural Health Transformation Program has been a topic of conversation significantly here in Pennsylvania. And many applications of states across the nation include some element of mobile health in them. And so Pennsylvania is no different. There's in the application, mobile clinics are listed in there as one of the initiatives that the state wants to focus in on in terms of healthcare delivery, in terms of outreach. And so I think what we're seeing is that there's going to be continued investment in this model. And so trying to think strategically about how we do this in a way is going to be really important. So what I think this brings me to is there's this huge potential of decentralization of what we do by utilizing mobile clinics. And that's kind of the philosophy that we've been focusing in on here at Penn State with some of our researchers. And probably some main points with that. One is that these mobile clinics, many of them have some element of service. And that element of service and outreach can result in building longitudinal relationships with communities and build that trust. The second piece is that as much as technology has grown, there has become a widening gap, especially for underserved populations. And many in our rural communities are older adults that may not have access to tech. So that high touch experience of being able to have a face-to-face conversation with someone, I think is going to be critical. Irrespective of what happens with the AI boom, that connection with people is going to be critical. And mobile clinics are essentially that space that is coming to where people are located. So preserving some of that high touch, I think is going to be really critical. And then the final piece that we have seen is when you're going to where people are located, they're more likely to come back. So the challenges with, you know, those that are geographically isolated and far away from clinical research centers, here's the potential of CRCs moving around in different locations. Provides that opportunity for better retention rates for studies, having the opportunity for people to be involved in clinical trials that are farther away. And so that improved retention, I think, is also a huge benefit of this movement, as long as it's done in a concerted effort in an appropriate way. Okay, I'll end here with one challenge that I'll share with the group, and hopefully this seems relevant. I was sort of debating whether or not to mention it, but and then I'll end with some takeaways, and I'm more than happy to open up for questions. This is something that I think I've been struggling with a little bit, and I think is a challenge as time goes on. Great folks. So Georgetown University is there's the Center on Health Insurance Reforms. They submitted a sort of white paper recently, which was fantastic if you're interested in mobile health. They've got this report that comes out. Man, policy across the nation, all over the place. States are doing things differently when it comes to mobile clinics. California probably is the best in terms of structure, in terms of regulation, but other states are doing things that are unique. Arkansas just recently passed a bill to allow for more billing opportunities. And I mention all of this because the sort of the framework that we have focused on is leading with service. And so that has been a really key part of what we do. And I think a lot of mobile clinics do. But here's the challenge. So just looking at Pennsylvania, Pennsylvania has a pretty strict view of what a mobile clinic is, and that is it's a brick and mortar clinic. And so there's no specific infrastructure to have it regulated that it's a mobile clinic. And that really limits the possibilities. So if you look at the state of Pennsylvania, many of the mobile clinics are doing pretty much what we're doing. The focusing on prevention and outreach and screening. There's less direct clinical care that's happening, no specialty services. And that's really what communities need. And some of these rural locations, like communities are desperate for primary care services, for an urgent care clinic, for anything. It's not that there's a lack of health insurance, it's a lack of access to the healthcare providers. So a limiting factor has been policy. The other piece of this is reimbursement. So there's some challenges that exist in Pennsylvania with it. So I say this with like a little bit of a caution that as mobile clinics grow, I think the policy landscape is going to have to change to fit the needs that's happening in the community, because there's a limit to what services can be provided. And in turn, there's a limit of what can be done from a research perspective. And so some of that is changing. The states are making changes for policy across the nation. I wouldn't be surprised if other states follow suit to what California has done, to what Arkansas has done. But that is definitely a big hurdle that I see as some of this progresses about how this all fits into the landscape of mobile clinics. Okay, so I'll just end, I think probably the biggest thing that I can reinforce is that our key to increasing research involvement has been leading with service. That's been the first and foremost piece of it. And because of that, I think the leading with service allows for this building of trust, this foundation of trust that's needed in order to expand opportunities. And then the final piece is really leaning in to figuring out ways that we can decentralize the ways in which we do research. So that has been another sort of key initiative that we've kind of been pushing forward as we progress with this. All right, thanks everybody. Appreciate you listening. Hopefully that wasn't too much Penn State.
No, thank you. That was fascinating, actually, Mike. So we do have a research mobile unit. I think I saw Heather on. Heather, do you mind actually maybe talking like a couple minutes what our mobile research unit does? Or Jerry? All right, I don't see Heather unmuting. Jerry, do you want to maybe just a couple minutes so we can discuss with Mike the challenges of our unit?
Yeah, typically we take it out into various communities, kind of in a similar manner for outreach, engagement, promotional. It's like a big billboard. And we have also had studies use it as a location in their trial to perform research visits within various communities as well. The challenges are often about finding those locations that'll allow us to take the unit to. And I think that is probably the biggest and foremost challenge that we've experienced.
Yeah, thanks. Boy, it is tough. We've been, I think because we've had this blend of service and education along with research, it's opened up doors. we've been fortunate enough to work with different churches, for example, or the VFW, and different locations. The Moose is big, a popular location where a lot of people congregate. But places where we can park the unit and sort of have that mix of things that are happening. But definitely a challenge. That's it's hard to get it on the road if there's not a place to park it.
Yeah, I'd be interested in connecting with you afterwards and kind of exploring some more of how you guys made those connections and getting some more insight from you.
Absolutely. Yep.
So I was one of the investigators, probably the highest user of the mobile unit for research. So we had, several, our unit is a little different. It's, meant to do even interventional studies. There is a monitored freezer for drug use, as well as centrifuges and different freezers. So it was meant to be, for research. The problem is the money, right? So as somebody who used it a lot, it's easy to use it for industry studies because they are actually paying for that. They want to reach rural communities. They want to reach underserved communities. So they will pay for the rental of the unit. Problem if when you have NIH study, reimbursement is not the same. So it has been a little more, tricky for NIH studies to be able to afford the unit. Although it is a reduced rate compared to industry, but still it's significant that not many investigators would be able to pay that much, because you still have to pay the participants. You still have to do everything the same, with one extra challenge being, we process a lot of PBMCs. So when we get the blood, a lot of time you have to get it back to the lab within 2 or 4 hours, depending on the study. So that's tricky also for the staff to have to leave or get a courier to send it right away central. So there are some issues, but yeah, I really would hope we'll be able to encourage our use more and more for rural communities. It's definitely something cool that people come to see. Like you take it to different fairs and people just say like, what is that? What do you guys do? So it's an opportunity to talk about research to communities that had zero exposure to research before that. So it's been pretty neat, but the challenge, I would say most important, is really money for it.
It's so true that that it's somewhere around year 3 and 4 with most mobile units, irrespective of what they do, where financial challenges come into play. And that's that hard piece of sustainability. And so it's things like that. How do you get it? So here's our hedge is we're trying to lean into some of the other pieces of the institution, like education, where we can offset some costs by having course buyout time for faculty or whatever it might be to help support it, so that there's some stake of the game from the educational side of things. The same thing goes true for our outreach section of it opens up the doors for other funders potentially that are within the industry, that we can offset some of those costs to get the mobile unit on the road. And so it makes it messy, because there's also this challenge that for us, it's this, where do we live? We're not really just research, but we do research. We're not really just education, but we do some education. And we're not really outreach, because we do some outreach, but we also do it. So, it's hard for us then, I think, to live in that space, because there's not really like one backstop. So there are pros and cons to each model. But it seems like most mobile clinics, it's tricky, even if it's clinical. I mean, getting revenue generated, especially for the state of Pennsylvania, it's impossible right now. But that makes it harder to make it operational.
Absolutely. Really?
Hi, kind of going off of what Dr. McCumsey and what you said, I'm a little bit curious. So in urban areas, when Jerry takes the mobile unit out and does some diagnostic testing and the test comes back positive, there's recourse because insurance rates are not that low. you can hand them a note and say, here, make an appointment and do some follow-up. But if we're going out to rural areas, then uninsured rates are much higher. So then the conundrum is, what do you do? So in your case, I'm curious to know, have you run into issues like that? And then what is your recourse and how does that impact trust and, this sort of progressive building of trust?
Yeah, I think we see this in particular at some of the dairy farms with migrant seasonal farm workers. So we have different business affiliations with either free clinics or other entities that help us with some of that processing. So for example, for those without health insurance, we partner with a free clinic that is able to then get that person registered and then provide additional care through the hospital systems. And then we also leverage, like for the cervical cancer screening that we're doing currently, there's funding through the state that will help with ongoing care if someone has a positive test result. So we leverage that system basically to help cover the costs for people that don't have health insurance but have a positive screen. So it's been trying to find those like resources here or there to cover in those scenarios before we go out, because I'm with you, because it's easy to screen and do early detection, but what do you do when something comes back positive? That's the scary piece.
Right.
And so we've tried to be intentional. If there's a program that we implement, that we have some sort of mechanism, irrespective of insurance, to get that person in the care that they need long term. So that's how we've done it.
Thank you.
Jenny?
This is Janine Leone. I'm just going to ask a couple of quick questions here. So when you were starting to build this out, what was your staffing model, or especially on the outreach side, how much and how was that all grant funded? How did you manage that?
Yeah, mostly grants. And then we were able to we have one project manager that's paid for by the College of Medicine, which helps. And then some of my salary is actually supported by our Cancer Institute and CTSI to do some of this work. And then we lean heavily on course internships and volunteers. That's how we keep the overhead less. So it's beneficial because some of this students need sites for courses. So as long as we have oversight on that, that's helped. And then it's we have an abundance of volunteers that's hard to manage. That's been probably the challenge, is we need another project manager just to manage the volunteer portion of it. So a lot of people that are good natured but need some additional training and support to be able to be at that point where they could be helping with recruitment or doing the HPV self-sampling with all those sort of things require additional training. And so that's been probably a log jam for us, is how do we leverage that volunteer passion.
It's impressive what you've built out in a pretty short period of time, though. Well done.
Hey, thanks. I go back to that story initially, it is, I'm sure you've all seen it. Like, there are people that are in need across our state. And every time we go out, there's, another story that really is emblematic of why we need to do this. And so this is a project that's passion filled. I will say too, we didn't really get into this, but I almost see some of this work, if there's a way to fund it, is a little bit of a burnout mechanism. Like rolling out with researchers, with other clinicians. It is so rewarding to see, how they feel connected to the community and be out there on the road. And so, I hope that as time goes on, institutions will be willing to support these types of initiatives and mobile clinics and mobile research centers, because it provides that value and that connection with people that gets us out of the computers and onto the road, which is really beneficial.
And then, did you say you connected with your farm stuff through your through the ag school, or how did you break through? I'm a farm kid from Clarion County, and I was a 4-H'er. My kid goes to Penn State. I know your terrain, and I know the dairy farm situation very, very well. So that's a tough population to break through. So thinking about all of our, we don't have the dairy farms. We've got very large different types of farms here, with a lot of unmet need. So
we've been fortunate to have some great connections with vets, and so our ag department is a little so it's the vets are not necessarily providing care to the animals, but they do provide consultation. But they do consults all across the state. So that's been the connection to farmers, and then the Farm Bureau has been super supportive as well. That's been another group to help us connect with farms.
I want to come work for you in a couple of years. This is be great to get back.
Well, great. Thank you so much, Dr. McShane. That was a wonderful talk. I just want to share, and then there's a few QR codes. This will also be in the email as well. A feedback survey on the right there. The middle one is to become a member of the CTSC if you're not already. And then the one on the left is how you can look at all of our upcoming sessions for the Distinguished Speaker Series. And then I see a lot of accolades in the chat saying thank you and great insight and enthusiasm. So thank you so much for coming and sharing your work with our CTSC.
You bet. And if you're in State College, look me up. I'll take you on the ride.
Awesome. Well, thank you so much, everyone. Have a good rest of your day.